palpating the lateral and posterior pelvis. So our reference structure is going to be our ASIS and sartorius. You can see it there. First structure that we're going to go into is TFL. Okay, the epimesial grooves are identified by the black marker, and then you can see the circle identifying the greater trochanter. Okay, you're going to go perpendicular to the fibers of TFL, moving back and forth. Once you've identified said fibers, if you want to assess the tissue quality, you would go perpendicular to them, parallel to them. Okay, you'd come behind the patient, and then you would be adding length to the insertion in the origin by going into extension, adduction, and then external rotation. And you're looking for non-uniform lines of tissue that have a higher amount of strain as you add stress. That is to say, add length. Okay, from there, we also got into the glute medius, and glute maximus, and glute minimus. So let's go to the glute max first. Okay, so you're going to find that coccygeal line, and you're going to imagine a line from that coccyx to the greater trochanter, and that's going to be the inferior line of the glute maximus. Don't be fooled. Things south of this are not the glute max. That is adipose tissue as well as the quadratus femoris. Okay, so as you go perpendicular to the fibers and noting that inferior epimesial line, you'll be able to get a sense of outlining the glute maximus. Okay, in order to assess the tissue quality here for mechanical tissue, adverse mechanical tissue tension. Okay, so you're going to add length or distance between the origin and the insertion. So if you're on the posterior fibers, you're going to go into flexion, adduction, and then external rotation, adding tension to the fibers of the glute maximus. Okay. If we're going to go to glute medius, okay, so we're going to go from the greater trochanter to the PSIS, and then walking an imaginary line to there, and then we're going to find the posterior border of the glute medius. Okay, once again, walking our fingers ant-like or caterpillar-like along the fibers and identifying, just outlining the borders before we assess the tissue quality. Okay, so because the glute, thinking about the layers, it goes glute max, then glute medius. We don't have to layer too much here, but you, to get to the glute minimus, you will need to. Okay, if we were going to look at the, assess the tissue quality, now that we've outlined the tissue, palpating hand is going to go parallel to said fibers if we're going to do the posterior, and then we're going to go back and forth and then add length to these fibers by going into the adducted position. Okay, you can also go in, yep, there you go, adding distance between the origin and the insertion. Okay, so you're going to go into what is internal rotation only because you're going to take that greater trochanter and roll it anterior away from the insertion of the posterior origin of the glute medius. Okay, glute minimus, same thing. The difference here is because of the layering, we need to approximate the more superficial tissues, that is to say the glute medius, as we get deeper and push into the glute minimus. Keep in mind the fiber type, or the fiber orientation being in that fan-like orientation. This is going to be important not only when you're outlining and defining the muscle belly by palpating perpendicular to them with your fingertips, but then also when you get into the assessment of the tissue quality by elongating the tissue. Once again, posterior fibers. You're going to roll the greater trochanter anterior away from the insertion of the posterior insertion of the posterior fibers of glute minimus. Also note the flexion. Okay, same muscles. Now going for the anterior fibers here. Okay, the key here is that the practitioner can bias these by having the patient abduct if needed, and then adding a little bit of resistance for confirmatory palpation. Additionally, with the anterior fibers, it's going to be different. That is to say, you're going to go into extension, adduction, and internal rotation of them, or of the external rotation of the hip. So there it is. Yep. Again, adding length between the origin and insertion, extension, adduction, external rotation, putting length to the anterior fibers of glute medius. Glute minimus would be exactly the same, with the exception that, again, you need to approximate or layer the more superficial fibers. That is to say, glute medius. Now the practitioner can get deep. Okay, and then going again using the reference structures of the iliac crest as well as the greater trochanter to determine the proper location. Okay, and then adding length between the origin and the insertion as you palpate parallel to the anterior muscle fibers, looking for adverse bands of tissue.